key position right now for the LHIN Family Health Team, and I put a picture of our brand new building that we'll be moving into in August, a staggered move of 4 different pods. And when Rob asked me to speak about a medical home, I decided to ask the other 9 physicians in our team what a medical home meant. They had building on their brains, so they told me it was the bricks and the mortar and the house that we would all be housed in, and didn't think really beyond that. And so I think that when we think about a house, it only becomes a home with the people that we put into it. And I think it's really important that all of you remember, and I think it leads on the discussion that Clark brought up, which is, who are these people that are in this medical home? I think that's a really important question. Clark and I bang heads on Thursday nights in our CME group, and he's always got some wonderfully provocative questions, so we might hear more from him as the day goes on. So objectives, you can tell I teach. I like to keep things super simple. 2 objectives. The first one is just to give you an example. It's not to brag. We don't have it all perfect. We're a medical home in the making. That's what we tell everybody. I also want to encourage you to either begin or to continue with a transition from silos of care. It doesn't matter what your silo is, whether you're CCAC, whether you're VON, whether you're a nurse practitioner, whether you're an audiologist. I want you to think about, begin to contemplate, continue your transition into something called a medical home. We've already heard about why a medical home, but there's a Cathyism that's number 4. We want to improve health outcomes. We know that we do that with medical homes and with team care. We want to enhance the patient experience. Couldn't agree more about patient accountability, but it's about enhancing their experience, and it really does make them more accountable. We've shown that with our smoking cessation program, for instance, with the % decrease in smokers in our practice by spending time with them and not having it be that doorknob comment at the end of a physical, or maybe not even brought up because we feel as physicians a bit dejected, like we're not going to make much of a difference. We make a difference when we put it in as a program and we talk about it and spend time. We reduce cost to the system, and I'm going to show you just a couple of examples about how we've done that in London. The last one is probably one that's nearest and dearest to my heart. I'm not going to spend too long on it, but it is so important that we have this great opportunity to improve the patient and the allied health professionals' job satisfaction. We have to build sustainable models of care. If it's not sustainable, we won't spread it. Nobody's going to buy into this. It is going to be that fire hoop and no one's going to jump through it, not our brightest and best graduates that are coming out. I did a talk for the Family Practice Interest Group at the University of Western Ontario, and my daughter, who's at Ivy Biz School right now, looked at the slides and said to me, "You're going to put everybody to sleep. Mom, the number one thing that you have to offer people is your absolute passion for primary care." When I graduated, my father said to me as I walked off the UWO stage, "Congratulations, you have guaranteed receivables and no accountability." And I thought about that. He's long since died. He would be incredibly proud of this group of people in this room, that we are, as a population, standing up and saying, that's no longer good enough. We want accountability. We want equality. So I love going to work. And the reason why I love going to work is that we have a family health team. We pulled that family health team together. It's a process. It takes time. It doesn't happen overnight. So for those of you who are discouraged or you've got obstacles in your way, just remember that Vinny will remember conversations I had back with him in 2008, 2009. Took till 2010. Our roster's grown from 9,100 up to 15,000 is projected. So we're working hard on taking on those unattached diabetics. I think we've taken on 48 of them. So the number is no longer 200, okay? Physicians have grown. I'm a big proponent. Build it and they'll come. I cannot, nor can Rick Zoldas, our executive director. I hope you get a chance to talk with him. We cannot accommodate the new physicians who are coming and knocking on our door to join our practice. Allied health professionals, we hope, well, I'm being smug here by putting 8.5 in red. Rick knows it's probably going to be 8, but we're hoping for more allied health professionals. Programs that are available in various stages by different levels of adoption. Some of them, the primary provider is our social worker. Some of them, it's our dietitian. So in various levels of and stages, we've developed programs. As I said, we have 4 sites. We're going to amalgamate into one in August. We've joined Healthcare Connect. We use Healthcare Connect. We work with them to, I'm going to say, improve the opportunities within Healthcare Connect. It's a good communication that we have. After hours clinic, open access, accessibility, we've improved upon, and we have 1 electronic medical record. So that's just where we're at. We talked about the pillars of a medical home, and these are principle-based pillars. What does this really mean? I don't want to read these all out to you, but what does it practically mean? Jan gave you a trip down memory lane. I'm going to give you a very short one. It's my memory lane, and it's because I lie in bed at night beside an emergency room physician. And he said to me, "Oh, Cathy, the concept of a medical home is not new. My father was a general practitioner in London for 50 years. He looked after the young, he looked after the old, he delivered babies, he buried the dying. He knew a lot about ailments, medications, diseases. He taught at the medical school. He implemented the first immunization program in Elgin County. This isn't a new concept." And then we talked about the fact that it was done by one person. And is that a sustainable model? Because I hear and I read, there's a beautiful article for those of you who would like to read it in the Annals of Family Medicine, that talk about the fact that if we take a practice of 1,300 patients and we just simply look after 10 chronic diseases, that's it, that's all we have to do in our day, and we try and implement the guidelines, the best practice evidence-based care and prevention or case finding for those 10 chronic diseases, we as physicians, nurse practitioners would spend 10.6 hours of our day doing just that. No time left over for anything else. So is that a sustainable model? 2007, there I am. I'm at the center, I'm a one-man band, I'm trying to liaise with the university and attend meetings, I'm trying to see patients, I go back and forth to the hospital. I try and know who CCAC is, I have a Walmart greeter as a nurse, I'm not increasing her scope at all, she just puts people in the room. I have an accountant who's telling me that I can't afford to keep going with the model that I have, that I don't bring in enough income. And then there's my family in the corner, kind of tossed aside. And I'm thinking, no, this really isn't sustainable. I talk about what was I doing back then that met this medical home, the pillars of this medical home. I was trying to be patient-centered. I was trying to be their personal family physician. I gave myself a yellow for comprehensive care because by 2007 I stopped delivering babies and I figured I had huge gaps in my knowledge. Continuity, if I was there, they saw me. If I wasn't, they didn't. I was trying to teach, so I thought I was doing an okay job. But there were a lot of the other pillars that were missing. So, is it sustainable? Well, it's kind of complicated, isn't it? Our jobs, our profession, our trade have become very complicated. Patients want more. They want a lot more from us. They want more office hours, they want email, they want phone contact, they want faxes, they want follow-ups, they want more coordination with specialists and insurers, they want more discussions. They want longer discussions. They don't want paternalistic care. They want patient-focused care. They want more expertise from all of us. And how many times have all of you had a patient bring in, I saw it on television, and they asked me to ask you about it. saw it in Chatelaine, and I need to know what your opinion is. The healthcare system expects more. We talk about that accountability. More screening for depression, more case finding, more talk about risky behaviors, more documentation. Tom's father used recipe cards. When I cleaned his home out 10 years ago, I found recipe cards dating back to the early 1940s on patients. And now we become data entry clerks. It's my pet peeve with the EMR, to be quite honest with you, is figuring out a way to get all that great data in there so that I can pull it out and look at it. So in 2007, I said it's not sustainable, not for me. What am I going to do? And I talked about the bus, and I tried to find physicians. I felt like, I don't know, I hope no one's a used car salesperson in their spare time, but I felt like a used car salesman, going out and saying, you know, the very essence of all power to influence and to facilitate change lies in getting the right people on the bus. So I went around trying to find people to get on the bus. And I said, you know what, if we get the right people on the bus, we need people with the same vision. It's absolutely important to have the same vision. And if you have a vision and you have the people together, then you need governance. And that's the second thing in the list that you need to make sure you do, is to figure out that governance, whether it's provider-based, whether it's community-based, but you need rules to play by. And then the electronic medical record. And I don't think it matters which one we use in our province. They all have their pluses and minuses, and we can argue the pros and cons. But you need some way to communicate with everybody about the patient. And we need patient access to those EMRs, and that'll come. And then we need to decide what it is that we want to do, where we want to go, what our programs are going to be. To a certain extent, our government, our LHINs, our population of patients has decided that it's diabetes, that it's open access, that it's COPD, that it's asthma. But we need to decide that as a team, looking at our own individual population of patients, and we need to be able to do that. I remember so well getting surveys from the university saying to me, I want to know about your diabetic population. I'd sit down, my heart was sinking, I'd look at the wall, there's 2,500 charts up there. How many diabetics do I have anyway? And I'd ask Nancy, my secretary, how many diabetics do you think we look after? 60? Okay, 60. Really inaccurate data collection. So we need to be able to measure and know our rosters so that we know what programs we want to provide. And then we need to be able to measure it, and we need to know how to do it. We need to know, I use measure and QI interchangeably because that's how we make changes in our own behavior. I figured out I had prescriber inertia. I believe much more strongly in lifestyle management, and I compete with the McDonald's on every street corner and the Tim Hortons now who have you ever seen that large cup of coffee from Tim Hortons? That is a pot that people bring in to drink, and some people drink 2 or 3 of them. How do I talk about palpitations and lifestyle when I'm competing with some of the best marketers in the world? So we need to be able to measure, we need to know what that means, we need to educate ourselves as physicians about that. That to me is deciding if we're on a successful trip. So vision, I know, physicians hate talking about visions. So they'll all go to sleep when everyone else in the room who's a policymaker brings this up. But I'm going to actually make a copy of this and put this on the wall when we have our board meetings, because every time we struggle as primary care providers about an issue, we have to make sure that we take ourselves and our own self-interests out of the equation and say, what's our vision? Where are we going? This is about the patient. We're all patients, so let's make sure that we all are together in the same room with the same common vision. I'm going to talk about, sorry, I'm not going to talk about this slide first. It's self-explanatory, isn't it? I've spent my life cleaning up EMR records on call for some of my colleagues, and they for me as well. But you can't get data out if you don't put it in, and you can't get it out and measure it if you don't know what it is that you're looking for or what we would call a reportable field. So you need to decide on those outcome measures. What do you want the patient's outcomes to be? Process measures, what do I take ownership for? Examining feet. You know, I mean, that's my job. I need to do that physical exam. So process measures, and then balance measures. How are we going to look at our system and know that we're making a difference? So standardize your data. There is no slide for governance. You may, I'm talking about these 5 things that I think we need to do, and I don't have a slide on governance, and I tried to push Rick and our chair of our board, Dr. Catherine Walsh, to give me a slide. And I think the only thing I can say on governance is that it's a process. It's very challenging to take 10 solo practicing business, in my case women, put them all together in the same sandbox and expect them to play by the same rules. So we have spent a lot of time getting our governance in place and trying to organize it so that we have a clear process of who leads this discussion and decision, whose responsibility is it to take this idea forward, who do I report to on this? How do we make decisions, and how do we function as a group of physicians and allied health professionals? What are our rules that we work by? So it's a critical process, and we have a provider-based governance, and I think that it is one of the major hurdles to getting our solo family physicians into teams. I truly do. And I think that when we get it right, when some of the provincial teams get it right and get great functioning governance, it'll be important, just as we go, talking about open access, we go talking about governance. So programs. Back in 2005, when we started to do some program writing in our practice, we talked about what does that mean. And a program starts with a good logic model, goes through a process map to walk the patient through the office. It starts with the patient. It doesn't start with what I want to do. It starts with what the patient's needs are. And then we have to figure out what are our educational needs for our allied health professionals, for our physicians, those outcome measures, all of the measures that we want to do. And then how do we spread and sustain this program? I hate this slide, but I want to let you know that you have to do some homework to do these programs well. And this is information you can get from the Ontario College of Family Practice, that you can get from the quality book that is on the Ontario College's website if you're trying to develop new programs. And I think it's very, very important to understand it, because this next slide is one that was presented at our diabetes spread meeting, monthly meeting. And it was the new ideas that have been organized in how we're going to improve our actual delivery of diabetic care. And that's all of the little boxes around the outside of the pillars of chronic disease management. So if you look at health organization, it'll talk about a standard referral form. It'll talk, and that's, not all of the physicians were using the same referral form. Some were writing a letter, it was time consuming, some were ticking a sheet. So we found out there was a gap there in the organization and standardization. There are gaps in our clinical and our education, and there's gaps in our directives. We have to redo some of the directives for our allied health professionals. So we can't fix things if we don't know they're broken, if we don't measure them, and we don't then evaluate them. I'm not going to spend a long time on this. It's just about the data. It's about making sure that you have something, no matter what your EMR is, that you have a template or you have a place, a standardized way that you can put this information into the computer with all of the important outcome measures so that you can get the information out. And this is just an example of the template that, and I brought diabetes just because I know that it's a hot topic. In our EMR, all this templated stuff flows into a flow sheet. And then the flow sheet is the thing that I love, because I can look and I can see what's happening with this patient over time. So for my diabetics now, I've had the EMRs since 2006. I can look back that long and see the trends. I can print graphs. I print the graph and I say to the patient, look what's happening to this outcome measure. That can then be put into a sheet like this, a graph like this. And I purposely brought the data from 2008 to 2010. And I stand in front of you very smugly saying, I thought I was doing a great job back in 2008. The green means I've met those outcome targets. The yellow means I'm kind of getting close to them with the population of patients I'm working with. And the red means I'm nowhere near. So that was incredible and powerful information to be able to take away and say, where are we going to target our resources? And what ended up happening was we then incorporated the concept of a teamlet, a chronic disease nurse. We strengthened our referral processes to it's called LHIN, our local diabetic education center, to make use of our diabetic educator. There were many, many things that went into this program so that over the course of a year and a half, we were able to improve outcomes, outcome measures and process measures. So we make a difference for patients in their outcomes. We make a difference for patients in their quality of life. And this is really an important slide to me because this is our COPD. And we looked at MRC grades. And MRC grades mean if you're along the, if you're along the bottom, MRC grade 5, that's basically stage 4 COPD or palliative COPD. The MRC 1s and 2s are milds, 2s and 3s are moderates. What we were able to show was that we basically flipped a lot of our moderate COPD patients into the mild category. So the quality measures for them, their shortness of breath, their activity, their quality of life improved. I like this one too. Again, this is older data. The data now just shows sustainability. So if I showed you 2010 to 2012, you just see that line bopping along in the same place. But this red time, if any of you have done access, red time zone or value-added time is the time you actually spend with a caregiver, in this case me, in my office. So you can see that you spent, when this all started, 20% with me, and the rest of the time, 80% waiting someplace in my office. I can't imagine how frustrating that would have been for all the patients. And you can see over time that that line has gone up, so that now the red zone time is around 60%. Now the interesting thing is that in that other 40% that you're waiting, you're actually seeing other care providers. And so I hope that we can have a slide in the near future that shows that your time in the office is actually very little time waiting and a lot of value-added time. Max paxing that visit, I think that's the term that Rob used. So the patient experience changes in a team. And then finally, this one was COPD patients who reported a visit to the emergency department or a hospital admission over the course of the time that we were part of QUIP, which is now called Health Quality Ontario. Our number was 6% and the provincial number was 23%. So if you put in place a program, it does make a difference in terms of system utilization. Everybody's talked about open access, and this is, I don't expect you to be able to read this. It was a research project just to talk about the fact that we link to Western, to the university, and we have students come out and we teach, and this was a very industrious, she's now a practicing physician in a family health team in Ottawa, who looked at open access and looked at it between one practice that had just put open access in and another traditional booking method, which was come when you can, squeeze you in when we can, the overflow goes wherever it can, and the initial time, third next available appointment, which is if you call, when can you see your family doctor, in the open access practice was 0.5 of a day. In the traditional booking method was 32 days. So it just gives you an idea, and I'm going to pull up two slides. So when we put in open access in one of the practices, there was a 16.8% reduction in after-hour clinic visits. And then the weekday after-hour clinic visits reduced by 10%. So this is the after hours or the walk-in clinic type appointments. And then the impact of open access on the emergency department visits is quite significant. The non-urgent ED visits, these are the CTAS 4 and 5 visits, went down by 22%. And that's over the study period April to September of 08 and April to September of 09. And then the weekday, so people who went into the emergency department during the time the office was open, decreased by 26%. So we can change the system with open access. The interesting thing is the practitioner who has the traditional booking model has just gone to open access. So we'll be looking at all of this data again, April till September of 2012, and doing a comparison. Be interesting to see about sustainability in the other practice and the hurdles for that versus whether or not it's a repeatable group of data. So open access, reduction in visits calculated per 1,000 patients. Traditional booking actually went up over the same time period. So we make a difference with patient outcomes. We make a difference with patient experience. We make a difference in our system care costs, and we make a difference with our physicians and our allied health professionals in terms of their professional satisfaction and practice satisfaction. How do we get everybody to do this? I mean, I can go around, Rob can go around, people that are involved in family health teams can go around and can say, you know, what a great thing it is, but it's very difficult when we have the notion that quality improvement doesn't take into qualitative improvement. And I'm very nervous when we start to build our building that we're just building an impersonal hospital in our community, and we really don't want to do that. We want to continue that Cheers bar thing where everybody knows your name. We want to take that family practitioner, that old style family practitioner that people knew, and transpose that into this new concept and into this new medical home. I think that's important. So in Ferris, there was a great quote by Justin Palmore. He's a physician, and he said he fervently believes that everyone is worthy to serve the suffering. It's not a matter of worth, it's a matter of heart and a matter of passion. And as this picture so candidly portrays, a matter of willingness to progress in a way that best serves the human condition in every aspect. So if I can comment on hubs, I was going to finish there, but I've been listening to this concept of hubs, and my mind's always working, and Rick is going to kill me. He's sitting back there. Rick's our executive director, by the way, and he hears about 4,000 ideas a day from me. Why aren't our teams then going to take in more or assimilate more FOs or fee payment programs? So I would challenge the family health teams in the room, including myself, that if we have, and we're building and we're in the making of these medical homes, we can invite other FOs and other solo physicians to be part of our teams going forward. And I think that's how it's going to spread. And I think Malcolm Gladwell was right. We've got to get to that tipping point, and we'll get there. So thanks. I know you're all hungry.
I really want to thank you, Cathy, for that presentation. One of the key things there, I think, is with all of that quality improvement she's doing, she's really interested in making her medical home a comfortable place for people to have their healthcare needs addressed. And so it's really nice. I think it'd be really nice to be patient in your practice. This morning we talked a lot about accountability and what we might measure. And just in terms of Cathy's practice, I'm going to give you a list of some of the things. She provides comprehensive care, that's measurable, cradle to grave. She uses an EMR to define patient panels. She's done a lot of team-based quality improvement initiatives. She helps to educate healthcare professionals, and she's improved access for her patients. And these are all part of the pillars of the family home concept. They're things that as a primary care lead for Southwest LHIN, I encourage all practices to do. And so what we've done today is we'd like to formally acknowledge that, and I'm going to hand it over to Mike.
Thanks very much, Rob. On behalf of the Southwest Local Health Integration Network, and on behalf of the Ontario College of Family Physicians, I'll ask Jan and David to join me to present this to you. We'd like to formally recognize you for the great work that you've been doing on the patient-centered medical home model. We tried. You can see from her passion, the way she can articulate her vision for ideas. And the question that you asked the audience is, how do we get other people to do this? I think it's continued leadership from people like you, and we want to recognize that leadership through this award today. So congratulations.
I'm totally speechless. That never happens. I'm sure you know that. But I accept this not on behalf of me, but on behalf of the team that's around me. And on behalf of the patients, you'll be really amazed to know how much the patients look at all of the things we put up in the waiting rooms. So this is going to be a wonderful addition to our waiting room and to our new family health team building. So thank you so much.